So in this session we will be covering about the remaining. So that is, in case already the patient is on arterial line, how do we draw the sample and what are the possible complications and how we can prevent those complications and what are the sampling errors we'll be seeing in this video. So already the patient is on arterial cannula. How do we take the sample? So here as a nurse we have to keep in mind the precautions, because here we are going to deal directly with the arterial line. It should be very much strict aseptic technique to prevent transmission of infection, and see that there is no air bubble getting entered into the system whenever we take the sample or draw the sample. And we always need some sort of dead space, because you have the connection ports, that is you have the three-way whenever we draw the sample, and on the three-way, that small opening of the hub, there is high chance of dead space. So see that whenever we draw the sample, we all know that in case of arterial line or a venous line, we take the at least minimal of 3 to 5 ml and discard the blood, and the remaining fresh sample will be taken for the analysis, because there might be dilution of the line, heparinized saline, which is on flow. So that's the reason we always the patient will be on a flush solution in order to maintain the clotting or preventing the clotting of the arterial line. So see that the flush solution must be either stopped, or we will be removing around a discard blood of 3 to 5 ml, and then we will take the fresh sample. And another important point which you have to keep in mind is that whenever you draw the sample, there should not be any air into the heparinized syringe, as well as from the dead space there should not be any air bubbles entering into the system. If it enters into the system, patient may develop air embolism. If it is going to enter into the syringe, then now the full apparatus may get disturbed and you may have fault reading, or you may need to have a resampling as well. So these are keeping these precautions before you start the procedure. So how do we take these samples? So catheters are always aspirated with a syringe. Only fresh new heparinized syringe will be used. Undiluted arterial blood fills the catheter, and this is always being accomplished by having a stop clock connected between the catheter and the infusion line. As well as you have the certain hospitals will be having the continuous flush. See that the continuous flush is very much patent, and you maintain the arterial cannula throughout the procedure as well as after the procedure. So in post procedure, what we do is that we have to dispose all the materials and remove all the PPE as we already wore during the procedure, and see that you will be checking for the site for any sort of bleeding like that, and if necessary you have to maintain those in the post procedure record area, and check for the sites of bleeding. Might be if it is a like a puncture site, arterial or brachial or ulnar, then bleeding must be assessed or hematoma must be assessed, and see that we should always immediately transfer the sample to the laboratory with having a ice pack in it, so that you have the exact findings of the patient, and see that always in the post procedure keep the patient comfortable, and he will be documenting what is the time you have taken, what was the date you have taken the sample, which site the puncture was performed, whether the Allen's test was positive or negative, and what was the remedy done before and after the sampling, and was there any procedural complications such as hematoma or bleeding must be documented thoroughly into the nurse's chart. And see that we will be discussing if there is any unexpected values or concerns regarding the patient condition along with the physician or might be the consultant immediately. So after procedure, as I told you, always scoop in one hand technique, never recap with double hand. There is high risk for injury to the nurse's hands, such as needle stick injury. Always expel the air bubbles, cap the syringe and roll the specimen between the hands. We are not going to do a vigorous shaking. We have to gently mix up between both the palms in a rolling technique, and then we will be sending the sample to the laboratory without any leaking. And of course, see that you label the patient sample immediately. So because in case if you are going to label it previously, there is high chance of mixing one patient sample with the other sample. So as soon as you take the sample, immediately you write the sticker in hand itself, and only you have to peel the sticker and immediately place it onto the ABG blood collected syringe needle. The possible sampling errors would be inappropriate collection. That is, if you are not following the strict aseptic technique, or you are not expelling the air, not rotating the sample, or not choosing the right site, all these can develop an incorrect results. So the most common reasons for an incorrect blood sample result would be presence of air in the sample. Might be you are not punctured the artery, but instead you have punctured the vein, you get an abnormal result. And might be very much small or very minimal quantity of apparent where the blood has lysed, thereby you are getting a improper value, or might be improper mixing of the blood after drawn, or might be you are transporting the specimen to the lab very delayed. So these are the possible reasons where we may develop the incorrect blood results in ABG sampling. So the possible arterial puncture complications would be, as we all know, hematoma, thrombosis, arteriospasm where the artery is getting, all the three layers getting spasm, thrombosis developing into the vein arterial area. Might be if you have damaged the vein instead of nerve instead of the artery, nerve damage, fainting and vasovagal response. So coming to the summary, ABG blood gas sampling can provide invaluable clinical information. So we need to remember that these measures are not static. Might be you take an FiO2 of a patient with 80% and you do the sample. It shows a very pretty good value. But suddenly if you reduce the FiO2 to 60 or 40, the patient condition is not stable. So that in those cases you will be having a difference in the sort of ABG values. So decision making should be always clinically correlated with the patient rather than just depending on to the values which is being obtained from the ABG analyzer. And see that the ABG analysis requires critical analysis as well as evaluation whenever we get the results from the lab. So to conclude ABG blood gas sampling, so it is a vital tool in management of critical care patients, and when interpreting ABG, obtain a patient's detailed history if the patient is awake, and if the patient is unconscious, try to obtain the history from the attenders, and then get the baseline status like temperature and vitals, and what is the outer supply, and is there any respiratory compromise or any cardiac compromise, and might be any cerebrovascular compromise. Then you can correlate and then you can go in for the analysis interpretation. So this is a small example of how the ABG sampling report looks like. Of course, there will be patient ID and what is one is the date and the time, and what is the how much in that day it is. This sample is the 248th sample. So you will be receiving all the total details in the blood gas report, as well how much degree centigrade it is being measured. What is, so here the down you have the entered data. So here it shows what is the temperature of the patient, what was the HB, what was the FiO2 setting, and with this the machine will be correlating and giving you the sorted values or measured values or calculated values, which is the pH. So in pH you will be seeing 7.463, so which shows that 7.35 to 7.45 is normal. So this here the patient is having slightly alkaline in nature, which is alkalosis. Next you will be checking the three parameters, which is PCO2 and the PO2. So here the PCO2 is around, so this is the corrected value, because in case if the patient is having a temperature of 37, then alkalosis might be, and when the patient entered data is 38.6. So here we can check the pH is that 7.439, which is approximately 7.44, which is giving you a data that the patient is not having any acidosis or alkalosis, and the pH is 47 and PO2 is very well maintained, which is around 123.5, and the bicarb is also very much stable, and water saturation is also 98.3. So this shows us a pretty good value where the patient is now stabilized in spite of a good O2 inflow. So this is how we have to correlate with the patient condition and then come to conclusions whether it is being compensated or whether the patient is having any acidosis or alkalosis, and we will also go in depth whether it is due to renal base or might be it is due to respiratory base. So a quick assessment. So you can go through what are the possible assessment of this particular content, and you will be able to give out the answers for the following assessment questions. So these are the possible references which I have done for the ABG sampling through the net source. So I think and I hope that you all enjoyed this ABG sampling. How do we do it in artery puncture, or what are the possible tests we need, what are the requirements we need, and what are the things you have to note before you take the sample, such as I told you the ventilation, FiO2, and the patient temperature, which plays a major role, or it can have certain biases such as how much sample you take, how much vigors you have to trigger the sample, and what is the procedure, sterile technique, and how you do the lens test and so on. So I hope you all enjoyed this video. So if you have any suggestions and queries, please follow the YouTube, as well as you can put on your comments onto the YouTube. Thank you.